Hello everybody. After I posted on YouTube my talk on my views on unstable intertrochanteric fractures, I have been getting lots of requests from mainly the postgraduate students about complications and how to avoid those complications. So here is an attempt to talk about some of the common mistakes and how to avoid them. Here is an X-ray one of my friends sent. That was his one of the earlier few PFN. This is the immediate post-operative X-ray, and if you critically analyze, there is varus of the neck. The fracture is open superiorly. That means the nail is acting as a spacer, and the surgeon has not made a proper reamed canal at the insertion site. The screws are longer due to the varus. The superior screw is definitely longer, and the problem of superior screw longer, as you all know, is either the superior screw breaks because it takes the load first, or the Z effect. Beak of the proximal fragment entering into the distal fragment, that indicates that there is severe varus, and that is an invitation for failure. Another case, a subtrochanteric fracture treated with nail, and the surgeon said that he had a lot of problem in inserting the nail, and it was abutting at the anterior cortex distally. This is the immediate post-operative X-ray which he had shared with me, and this is the attempted lateral view. You can see that the nail has been inserted in the reverse fashion. There is an anterior curvature of the femur, so the nail is also side specific and it has been bent accordingly. But unfortunately, the surgeon has used the opposite side nail without realizing that the curvature is posterior, and that was the reason why the nail was abutting against the anterior cortex. Immediately I had written to him on the WhatsApp that this is what has happened, and the resurgery had to be done, and iatrogenic fracture did happen during the resurgery. Even a case I recently did the implant removal, a nail has been used again in the wrong fashion. You can see in the second picture the curvature of the nail doesn't match to the curvature of the femur. Newer technique has a learning curve, and definitely PFN has a longer learning curve. Instead of talking on all these complications, let me talk how we can minimize this complication in this part of my presentation. It's a very busy slide. I will take each one of them subsequently. If we are doing regularly interlocking nailing, it's better to have your own personal set. The reason is the loaner set will have some instrument missed or the instrument not properly working, and you have to spend a lot of time struggling during surgery. So I advocate to you, purchase your own set. The foremost mistake is the varus reduction. This is due to the problem with either the positioning of the patient or with the entry site. This will lead to inability to pass both the screws. Second commonest problem I see is lateralization of the shaft due to This will lead to altered hip biomechanics. Though the fracture will unite, but the patient will have a abnormal gait, lurching gait. Here you can see the operated right hip is so much lateralized compared to the normal side. Though the fracture has united, but the liver biomechanics of the hip and the liver arm has been changed totally. This can be noticed by taking a pelvis with both hips X-ray. Normally, as you can see on the normal side, the line which comes from the outmost part of the iliac crest, when it is dropped down, the center is contained within that. Whereas on the operated side, you can see that the trochanteric has got lateralized. If you have to use a screw which is longer than 100 millimeter, especially in people less than 6 feet tall, that indicates there is something wrong. Our Indian necks don't require screws more than 100 millimeter long. Here is an example. That normally indicates that you have caused lateralization of the shaft without reaming for the nail. You have inserted the nail through the fracture site, so the shaft has got lateralized by about 15 to 20 millimeter. Our second reason is not releasing the traction, or it's the varus of the neck. All these three causes screw length required longer than 100 millimeters. Longer screws, though it looks perfect on table, but once you take out the patient from the orthopedic table, once the traction becomes less, they back out from the outer cortex and the head will be more prominent, and I feel that that is one of the reason for Z effect. If you have to ever use a neck screw of over 100 millimeter, think twice, recheck, there is something problem. Never miss surgical step. Even in a undisplaced crack fracture, I always fix with K-wires before making an entry. Otherwise, when you start reaming, the fracture opens up and leads to varus. By fixing this fracture, you can adduct and entry can be made easily. This is the entry being made with the centering awl. After insertion of the nail, always use an awl to make a hole in the lateral cortex of the femur. Our guide wires, 1.8 or 2 millimeter guide wires, are thin, long. They are not made for drilling the cortex of the bone. They go haywire, they bend and go haywire. So to avoid that, always make a hole in the lateral cortex with the awl which comes with the set, or make a hole with a drill before passing the guide wire. The inferior guide wire has to be passed first because the position of the neck screw is very important. So it has to be as inferior in the neck as possible. So always pass the inferior guide wire first. Then pass the superior guide wire. Normally, the inferior guide wire tries to bend slightly upwards and superior guide wire tries to bend inferiorly because the trabecular pattern. So don't keep changing the guide wire at this stage because that's the path of least resistance, and the guide wire which is very thin, 1.8 millimeter or 2 millimeter guide wire, is going to bend and go in the same path. So we can tackle that at a later stage. So as long as the guide wire is properly placed in the neck, you accept them. While passing the screws, it's always the derotational screw or the superior bolt is passed first. Whereas the guide wire, the inferior one is passed first, whereas the bolt, the superior one is passed first. As the name itself denotes, it's a derotational bolt. So it should act as a derotational bolt when you are passing the main cervical screw. Other advantage is the main cervical screw is very important. So once you pass the derotational bolt, you have a fair idea of the length of the inferior bolt. If you are using a 135-degree nail, normally the inferior bolt required is 15 millimeter longer, and if you are using a 130-degree nail, normally the inferior bolt, the cervical bolt required will be 10 millimeter longer. So you need not have to keep changing the main cervical screw or the inferior bolt. That is one of the reason you should pass the superior bolt first, then the inferior bolt. Here you can see the inferior bolt also has been passed. And once you pass both of them, see that you have released the traction, alternatively compress both the superior and superior derotational bolt as well as the inferior cervical screw so that the fracture gets compacted. Then I normally do dynamic distal locking, whether it's a intertrochanteric fracture or subtrochanteric fracture, but world over they advocate for intertrochanteric fracture a static locking, and for a subtrochanteric fracture a dynamic locking. Take a final AP and lateral picture on table after removing the jig before you shift the patient. Why the entry site gets lateralized and leads to varus? As you can see, the advocated entry for PFN is from the tip of the trochanter, but the bone is softer on the outer cortex and it is stronger on the inner side. So by the time you ream with a centering awl, you will be reaming more on the lateral side and less on the inner side. So automatically the entry gets lateralized. This is the schematic depiction. The entry made from the tip of the trochanter while reaming, getting lateralized, further getting lateralized. It is a proper position. The entry gets lateralized. The position of the screw also changes accordingly. This can be minimized by keeping the hand, as you can see in this picture, and pushing it medially while you are using the centering out to ream. Or you can nibble out the strong bony beak if already by mistake you have reamed like this. So in that case you can ream the stronger bone and then try to insert the nail properly. Just because there is fracture at the entry site, never pass the nail through the fracture site. This will act as a spacer. In which fracture do we insert the implant in between the fracture surface, you tell me? This is what it happens. This proximal expanded portion of the nail is acting as a spacer between the fracture surfaces. This fracture has gone into varus, as well as this will never unite unless the bone unites with the metal. This can be avoided by properly fixing the fracture. I will show how we should do it. Before that, I will show how this lateralization happens. Normally, a fracture is reduced well, and when the surgeon adducts the limb to make an entry, the thigh touches the perineal post. The adduction which is possible is very limited, only about 10 to 20 degrees. If the surgeon tries to adduct more to make an entry easy, you can see that the fracture opens up superiorly. The fracture which was undisplaced earlier gradually opens up superiorly. If this not open while you are adducting it, at least it will open. When you start inserting the 16 or 17 millimeter centering awl or the reamer, that will cause superior opening and leading to varus. This is all due to the thigh touching the cranial post. Then the surgeon insert the nail, and now do the locking. If it does the locking in the same position, as you can see, the fracture has been fixed in varus as shown in this picture. But if the surgeon abducts it to get the neck shaft angle proper, the fracture opens up medially also. This opening of the fracture medially as well as superiorly leads to screw length longer than 100 millimeter required, because the nail is acting as a spacer, and it's a normally all these nails have a proximal end which is 16 or 17 millimeter. So the shaft has been lateralized by almost 2 centimeter because of this. This is what I had shown you earlier. This is what has happened probably. Since it is not my case, so I can only say it's probably. Lateralization of the shaft. The same case, intertrochanteric fracture. After the union of the fracture, see the lateralization. The line which is in the outermost cortex of the iliac crest should be containing the greater trochanter, but here you can see the greater trochanter is much more outside. Newer implant doesn't mean that that problem has been solved. It is the surgeon who has to control all these factors. Just because using better implant, it doesn't mean that you can get away with them. Again, similarly, the same problem. Lateralization of the shaft has been happened. Schematic representation showing that trochanter is far away from the blue line. Varus of the neck makes the neck horizontal, and hence the length of the screw required will be longer, as well as the body weight is applied more on the varus position, the fracture normally doesn't unite. The implant either cuts out superiorly or backs out from the side. However, varus can cause relative neck length lengthening. Here is a fracture which can be fixed with a screw. This is the length of the screw which is required. Here, the same fracture superiorly it has opened, leading to varus. Length of the screw required is much more longer. Let me bring both the screws together. You can see the difference in the length of the screw. That is the reason why I said if there is fracture at the varus at the fracture site, the length of the screw required will be much more longer than what you expect normally. Derotational screw placed superiorly, or even the cervical screw placed superiorly in the middle or superior part of the head, is a problem due to varus. Due to subsequent loading of the hip, which is eccentrically loaded, as I said earlier, there will be superior cutting out of the screw or backing out of the screw, which both of them are seen in this case. Here is an example of beak of the neck going into the distal fragment. That indicates that the fracture is in varus. Getting a stable reduction with beak inside is only possible with a surface implant. If you are using an intramedullary implant, it's always varus. With a surface implant, you can achieve a good valgus as well as the beak can be inside. But in an intramedullary implant, beak inside distal medullary canal means it's in varus, it's an invitation for failure, or as Dr. Muki, my friends, calls, it's a day one failure. So what you have to get is the Shenton's line back in position. That's the best position one can get. If you cannot get that, it's better to get into valgus rather than getting beak inside. I accept beak which is outside causing valgus of the neck rather than beak which is going inside the distal medullary canal. So friends, try to get anatomical alignment as the first thing. That is little difficult to get. So second best option is getting a valgus. That's much more easier. Here is an example of a undisplaced fracture. The steps of the surgery: always fix with two KYs which are very accurately placed. Once you fix the fracture, you can adduct the limb. You can see the previous picture, the adduction of the thigh has been done. I always advocate much more medial entry. Though you are using a PFN, the tip of the trochanteric entry is the choice for the implant, but it's better to go in line with the medullary canal, and you will not repent for using this medial to tip of the trochanter or even piriformis entry. So this is the entry I make, and this is the immediate post-operative picture. See the position of the screw. The neck screw is inferior in the head as well as in the neck. As I said earlier, alternatively compress derotational screw and neck screw after releasing the traction. That is very, very important. Otherwise, the neck screw will be backing out in the immediate post-operative X-ray itself. Here is an X-ray with 3 months follow-up. You can see that there is no backing out. All the compaction, the fracture required has been done on table. There is no lateralization of the shaft. There are some unknown elements like this screw. 3 years it was in position. At the end of 4 years, it's backing out. Probably because of some loosening or some movement which happens with the nail within the medullary canal. It's a very ill understood phenomena. Even though the fracture unites, many a time the nail has broken inside a united fracture subsequently. I have seen few cases. So there is always a micro motion and stress and strain over the implant which is happening even on a united implant. Again, this is with the helical blade open and this is closed. The helical blade has come back. That indicates that it has lost the purchase which had in the head. Especially in a subtrochanteric fracture where you don't require this compression. But if you use this implant, this is an inherent problem with this implant. Other problem with this implant is it can allow only 7 mm of collapse. If your fracture requires 10 mm collapse, you cannot have that much. If your fracture requires 5 mm collapse, it compresses 7 mm. So, as I said earlier, newer implant doesn't mean it's always better. They are in the market only for commercial reasons. Here I have used a PFN-A2 in a subtrochanteric fracture where there is no role of helical blade compression happening, but unfortunately you have to lock the blade to prevent the spinning of the head and neck. So I had to lock it and lose little purchase. As you can see, the tack which I had hammered the nail little more inside has come back. The Trigen type of nail where there is an inferior screw which is having a differential threads compared to the main cervical screw. When you tighten the inferior screw, the cervical screw backs out, compacting the fracture because of this differential threading mechanism. Here too, the screw can be used in 3 settings: 0 mm, 5 mm, 10 mm settings, or some versions have got even 15 mm compression setting. That you have to decide on table before you insert the screw. You can insert in such a way that there is no compression happening, or only 5 millimeter compression happening, or only 10 millimeter compression happening. If you want anything in between, again, this is not a very good implant. So friends, I always feel that alternatively compressing the derotation screw and the neck screw after releasing the traction by the surgeon in a PFN is the best implant, because you are the surgeon, you will decide how much to compress a fracture. Unfortunately, the PFN is patented implant and everybody wants to have their own share in the market. These are some of the fighting in American court reports which ordered others not to manufacture PFN or similar implants, or including the derotational screw system. Hence, we have got many other newer generation implants in the market, because everybody wants to have their own cup of the share. At present, I feel that PFN is the best implant available in the market. If you can do that well, very good. But it is difficult to put two screws in the neck. It requires little more extra effects. So people shift to single screw system like the ZNN or the PFNA2, where it is little more easier for the surgeon. Here is an X-ray. My own case, 2006. I have not released the traction on table. This is immediate post-operative X-ray. 6 weeks time, you can see the fracture has collapsed and the screws are backing out. I learned this mistake long time back. So, not compressing the fracture and not releasing traction on table is the main culprit. Two more X-rays which some of my friends have shared with me. Again, similarly, the fracture, you can see that the screws are already out in the post-operative period. Here is an X-ray sometime from 2007. 2007 it is. Here you can see I have compacted so much on table itself that at 14 months there is no backing out of the screw head from the lateral cortex. This is very, very important. This how much to compress is the feel which you should know while you are operating on the patient. The immediate postoperative period and the immediate after 14 months, there is no change in the position of the screw. It is not backed out. The fracture is consolidated. So all the compression the fracture was begging for, I have achieved it on the table.
I have passed both the screws and
I
I
hope this video
alternately
runs.
compact
This is how
both the
I
cervical
compress
screw and
the
the
PFN, superior screw
derotational
and the
screw
inferior screw. Now the
that
inferior
will
screw I am
compact the
compacting.
fracture, and the
Again, I'll
screw
go back to
will
the
not be
superior screw.
lying
This is all
outside,
after releasing the traction.
and
So the traction has
this
been
will prevent
released
G
from the
effect.
foot end of the table. See, I'm feeling how much I'm able to compress. You should not compress one screw and continue to try to compress. So alternatively, compress both the screws till you are satisfied. Length of the screw is also very, very important. The TAD is very, very important, like the as said by Baumgartner. The tip of both the screws should be at the same horizontal level at the end of the surgery, so that when the hip is loaded, they take the load simultaneously. Here you can see the superior screw is longer. When the hip is loaded, the superior screw takes the load first and it breaks at the junction of the screw and the shaft. If both the screws are at the same position also is not correct. This is the here which is very, very important. You can see the both the screws are at the same horizontal level. When the hip is loaded, they take the load simultaneously. This is a very interesting article which talks about the length of the lock screw and the cutout and the outcome of the surgery. There are so many important things in this article, like position of the screws, jamming of the lag screw insertion technique, design of the lag screw, length of the lag screw. The commonest is improper placement of the lag screw and the short screw. And superiorly placed screws are some of the commonest mistake, where the cutout and the Z effects are more. Here is a superiorly placed screw which has come out immediately. Here is an example Professor Dr. Amit Pingat from Belgaum shared with me. This is after I conducted a workshop in that medical college last year. The first case, you can see the beak is going into the distal fragment, meaning the fracture is reduced in varus. So that is very, very important. The second case, here you can see the superior screw is longer than the inferior screw. That indicates that there is possibility of either the Z effect happening, if there is gap medially, or the superior screw breaking, because that screw is not made to take the load of the hip. So the inferior screw is the one which is made for weight transmission. So superior screw takes the load and breaks. So this is what I have replied to him immediately. First case is reduced in varus and locked statically, so superior cutout through chances are very, very high. Second case, longer proximal screw as well as static locking. Chances of Z effect or superior cutout, superior bolt breaking is very high. This article by Baumgartner, as I said earlier, is a landmark article which talks about the placement of the screw tip from the fovea. It should be less than 25 millimeter, both in AP and lateral together. As you can see, till 25 millimeter, there is no cutout. As the KD increases, the cutout, the red one, is gradually increasing. The same thing, up to about 25, there is hardly any cutout, but exponentially it rises afterwards. And in that article, the author advocates to keep the guide wire the center and very deep. But that is only possible for a single screw system. But for a double screw system like PFN, it's very difficult. So I advocate you to keep the inferior screw as inferior in the neck as possible and as inferior in the head as possible, and be as subchondral as possible. It should be less than 10 millimeter from the articular surface. As I said earlier, this TAD applies very well to surface implants like DHS as well as PFN. My friend Dr. Amit Rastogi, professor and head of the department of Banaras Hindu University in Varanasi, has done a lot of work on this implant and the cutout and the strength of the implant. And in cases where he used PFN, only one had a problem up to 50,000 cycles. But whereas a DHS, 5 out of 9 of the gamma nail, a single screw system, not the DHS. In the gamma nail, 5 out of 9 had problems, and that indicates that two screw system is definitely better than one screw system. This is the outcome of the study. This article which I quoted earlier, which talks about the length of the screw and additional anti-rotational hip screw prevent the cutout chances. Just to give an example, on a dark night, on a lonely road, you are walking alone, means you are worried what will happen. But even if a small child is there along with you, that is the derotation screw, you will be much more confident to walk on the road. Same thing happens. If there are two screws, the cutout chances are definitely less when compared to a single screw, because there are two surfaces which resist the cutout. The superior surface of the derotation screw as well as the superior surface of the cervical screw. Both of them prevent resist the cutout of the screw superiorly. The length of the dual lock screw is also very, very important. They studied the cervical screw longer than the derotation screw, cervical screw equal to the derotation screw, cervical screw shorter than the derotation screw, and both shorter screws. All of them were studied, as you can see in the picture on the left side. And They concluded in that article that cervical screw is longer, the derotation screw is shorter. That is, both the tips are at the same horizontal level is the best outcome. And if the cervical screw is shorter and the superior screw is longer, Z effect is very, very high. That is the one of the reason why I said earlier, if the superior screw is longer, Z effect is very high. There is least stress on the implant when the inferior screw is longest, and there is least varus malformation also when the inferior screw is longer. There will be smooth sliding of the neck screw as well as the derotation screw if both the screws are at the same horizontal level and take the load simultaneously. If the superior screw is longer or if there is gap medially, then there will be high chances of Z effect. Here you can see in the immediate post-operative X-ray the screw which is longer. This patient had subsequently G effect as well as breakage of the superior screw. Another case, immediate post-operative X-ray, the screws are much more longer, a subtrochanteric fracture. But you can see this case, the screws walks out immediately. Friends, to avoid Z effect, screw length should be adequate. Screw touching, the head of the screw should be touching the lateral cortex. We should try to avoid medial gap, and superior screw should be shorter than the neck screw. That is, there should be a minimum of 15 millimeter in a 135-degree nail and minimum difference of 10 millimeter with a 130 nail. Coming to the problems of subtrochanteric fractures, it's varus and many a time flexion deformity which is the problem. And here you can see if the tip of the trochanter entry has been taken, the nail will go much more medially and it is leading to varus. Both in AP and lateral view, this fracture has not been reduced properly. Here is a obese patient with a narrow medial canal. The surgeon had to do a lot, but you can see again, nail has gone much more medially, leading to varus at the fracture site. That should have been the line in which the reaming should have been carried out. Another case, again, varus and flexion abduction deformity. Friends, when you are doing a subtrochanteric fracture, always pass the guide pin from the piriformis fossa. Keep the guide pin parallel to the lateral cortex. Don't try to go medially. It has to be parallel to the lateral cortex in AP and parallel to the anterior cortex in lateral view. Very, very important. Once your guide wire or guide pin position is proper, then only open the medullary canal. Don't open initially medially. If you open this medially initially itself, your nail is going to be in that position always. If you don't open medially, that part of the bone acts as a polar. So the nail will remain in this part or the outer part of the canal. So as you can see in this case, this is the final X-ray of the same patient. Video of this patient is available on YouTube. You can search for Solapur Doc or Dr. B. Shivashankar. So the red line indicates the direction for putting the guide wire for intertrochanteric fracture and green one for subtrochanteric fracture. But friends, I take green one for intertrochanteric fracture and I take piriformis fossa for subtrochanteric fracture, and I am not repenting. Again, a guide wire has been passed medially, leading to varus at the fracture site. Though in this case the fracture has united, the entry is wrong. You can see lateral from the greater trochanter, even lateral, not even from the tip, it has been taken. There is varus at the fracture site. After the implants have been removed, the patient had a pathological fracture due to non-biological stresses on the hip. Here is a hefty lady. A tip of the trochanter entry if you take, you are bound to go and hit the medial cortex and break the medial cortex. So try to take much more medially or from the piriformis fossa. My tips for operating a subtrochanteric fracture on an orthopedic table. Normally, the huge perineal post is a hindrance for these fractures. When you try to adduct it, the adduction happens at the fracture side and not at the hip. So use a smaller size perineal post that against opposite side ischial tuberosity. Pass a Steinman pin into the proximal fragment and ask your assistant to adduct it by pulling it down. Then make an entry from the piriformis fossa and ream the canal. If you take care, then there shouldn't be any problem of flexion, abduction, varus in these fractures. This is what I normally do. I pass a Steinman pin and ask the assistant to adduct and interrotate when I make the entry. Here is an example. You can see the Steinman pin as well as the anti-rotation guide wire to know the direction of the neck. Entry is being done medial to the tip of the trochanter. Reaming is done almost touching the lateral cortex proximally. Then nail has been passed. Final sitting of the nail on table. Preoperative X-ray and immediate postoperative X-ray, which shows that both the screws are at the same horizontal level and the nail is in the lateral half of the proximal canal. If you take the tip of the trochanter entry, the nail will hit medially and you might cause a iatrogenic fracture. A shorter nail you can negotiate sometime, but longer nail, as you can see in this case, a subtrochanteric fracture, beautiful reduction, but the tip of the trochanter entry has been taken. You hardly can see the fracture in this reaming guide wire picture. Reaming has been done to our satisfaction. You can see that the reamer is bent here. Fortunately, the reamer can bend, but the nail cannot bend. And when we inserted the nail, there was a huge butterfly fragment because the nail hit the medial cortex, causing this iatrogenic fracture. This is my own case. So, if you see the anatomy of the femur, the neck makes an angle of about 135 degree with the shaft in young adults, but as the age advances, it becomes around 130 degree. These nails many times are manufactured from a straight rod, and after making the hole in the neck for the neck screw, they give a bend. So these 135 degree nails, many of the Indian nails available in the market are not 135, they are 140 degree. That is the reason why the inferior screw is not in the inferior part of the head. So the same thing which has been depicted overlying on the bone, you can see that the nail cannot be inside the medullary canal to properly place this neck screw in the head and neck if you're taking the tip of the trochanter entry. But if you take the piriformis entry, you can see that the nail is also inside the medullary canal as well as the neck screws are also both properly inserted. That is the reason why I always say take the medial to the tip of the trochanter entry or from the piriformis fossa. You will never repent. I am taking this entry for the last 10 to 12 years and have not changed so far. If you take the tip of the trochanter entry, a long nail, a 40 centimeter nail is only bent in the proximal 5 centimeter. So 35 centimeters of the nail has to go into the medullary canal. So if you take from the piriformis fossa, the whole nail can slide smoothly inside. Here is an example. You can see a piriformis entry is taken. Another example of an intertrochanteric fracture. Again, piriformis fossa entry, beautiful position of the nail. and the neck screw. Probably I would have used a little thicker nail in this case. This was a demonstration I did in Sancheti Hospital during Pune trauma course in 2016. There was a narrow medullary canal. You can see because I have taken the piriformis fossa entry, I am able to insert a 11 millimeter nail without any problem. If I had taken a tip of the trochanteric entry, probably I should have been satisfied with passing a 9 millimeter nail. See, the working length has been reduced to such a great extent. So I am happy to do this surgery with a thick nail which gives biomechanical stability rather than thinner nail. Another case, a PFN A2 has been done during a demonstration surgery at Akola. Not using an owl to make an entry in lateral cortex sometimes causes the guide wire to go haywire. So always use the owl to make an entry, then only the guide wire. Many a time the nail or the jig obstruct in the lateral view the position of the guide wire. As long as you can see the anterior cortex and the posterior cortex, the head properly, that indicate that your guide wire is properly positioned. Don't just rotate the jig to see the position of the guide wire. Many a time the jig only moves and the guide wire which is already within the head and neck bends at the junction of the entry into the bone. As you can see, the jig has been rotated, the guide wires are bending. So if you want to see proper view, lateral view, without the guide wire bending, catch hold of the anti-version guide wire and catch hold with the jig. Hold both of them together and rotate. That means you are rotating the head and neck as well as the jig. Both of them you are simultaneously rotating. Guide wire breakage is another important thing. Drilling of the nail itself and blaming the jig. This one of my friend has drilled the nail and he said that the jig is not matching, though it was matching outside. That indicates the reason is any time once you pass the guide wire, the assistant pushes the nail inside or due to small entry, the nail gradually walks out superiorly. Guide wire will be eccentrically placed in the oblong hole. So before you start reaming, always check with the CM, and if your reamer goes inside smoothly, then there is no worry. Otherwise, you should cross check what is going wrong. As I said earlier, always use a owl to make an entry with the guide wire. And another thing I said was inferior guide wire bends superiorly and superior guide wire bends inferiorly. That's the path of least resistance. So don't keep changing the guide wire. What you can do is while you're doing this, passing the screw, drill up to the straight portion of the guide wire, withdraw the guide wire, pass the drill little more subsequent further, and then you pass the guide wire. So that's what you can do. Intermedial reduction is very important. I use Steinman to get this reduction. This I have already talked in my earlier talk on unstable intertrochanteric fracture. Here is, don't keep on repeatedly using the same guide wire. Any time here you can see the drilling of the guide wire has been done and it is bending here. So this was recognized and it was immediately removed. So if there is resistance, we try to normally use hand drills only. I don't want to use power drills in these osteoporotic elderly patients to pass the screws. So it gives me an idea about what is happening inside. So it's better to use hand drills and hand reamers rather than power reamers in these cases. Friends, so many other things like not releasing the traction before distal locking, causing distraction of the fracture site. Not using a awl for distal locking so that the soft tissue or the tensor fascial lata pushes the sleeve anterior posteriorly leading to improper distal locking. The list is never ending. So always operate without skipping any steps. Each and every time when you operate, all the steps should be religiously followed. This is a recently I operated this case. I'm doing PFN for the last 17 or 18 years. 1999 I did first one. This is in 2016 I operated this case. No, it's 2017 I operated this case. Here you can see fracture is reduced. I'm using a Steinman and asking the assistant to adduct it, then making an entry. Entry made medial to the tip of the trochanter. Femur parallel to the lateral cord, both in AP and lateral. Then guide wire is in the center of the distal locking hole. Superior screw has been passed first. You can see here. Then the inferior screw is being passed, and the final AP and lateral picture on the table. Then distal dynamic locking has been done. These are the final pictures on table. If you do the surgery like this, there is no reason why there should be failures with PFN. Unfortunately, we skip many of these steps and we land in trouble. This is the immediate post-operative X-ray in the same patient. Such a beautiful reduction and such a beautiful placement of the neck screws. I make this patient walk immediately without any problem with the help of walker. Thank you very much. I hope these are some of the things I thought are very useful in the initial stages or initial time when we are doing the PFN. But as you graduate to do more complex injuries, there are many more complications which probably I will share sometime in near future. Thank you very much. Thank you for listening. You can write to me on my email drbshivashankar@gmail.com. I'll be ready to answer any of your queries. Thank you.